I am Dr. Mrs. R.A. Dighe. I am an assistant professor in Department of Microbiology of D.Y. Patil Medical College, Kolhapur. And today I am going to talk on MRSA and role of MRSA. This is in hospital and in community medicine. Now let's see what is MRSA and what is the full form of MRSA. MRSA means methicillin resistant Staphylococcus aureus. Staphylococcus aureus, which is resistant to an antibiotic named as methicillin. So it has got its name MRSA. What is this Staphylococcus aureus? Staphylococcus aureus is a gram positive cocci which is about 1 micrometer in diameter, and they are arranged in grape like clusters. They are non-motile, non-sporing, and they are known to cause diseases which are infectious or they cause intoxication. And they are a very resistant type of microorganism and very tough one because of their thick cell wall. And usually this Staphylococci produces an infection which is a localized one, suppurative, with pus forming lesions like this one, with the color of the pus is usually yellow in color. So this is type of lesion produced by this Staphylococcus aureus. Now if they become resistant to antibiotics, especially the methicillin, then the lesion produced by them are of more severe type and difficult to treat. So this is how the lesions which are quite big and they show a lot of pus deposition like this and a redness like this. These are the lesions which we seen typically with methicillin resistant type of Staphylococcus aureus. And why we call them a serious one? Because the lesion tends to be red, trendy, with a trendy skin around the wound. They are swollen, painful, oozing boils. Does not get better with typical antibiotic treatment which is usually given for any Staphylococcus aureus infection. And the serious symptoms are, they may give rise to fever, difficulty in breathing if it involves the respiratory system. Then the patient may complain of chills and fever and also chest pain. Well, as said, that Staphylococcus usually give rise to a localized type of lesion, but then it has a potential, especially the resistant one, have a potential to involve any system in the body and can give rise to pneumonia. If it involves the lungs, then it can get into the heart and can give rise to infective endocarditis. It can spread throughout the body, giving rise to sepsis, can involve the bone, can involve the genital system, the soft tissue. So it can become very severe and can involve any system in the body. Now, how do they become drug resistant? Or let us see the evaluation of antimicrobial resistance amongst this Staphylococcus aureus, from where this methicillin resistant Staphylococcus aureus has evolved. Staphylococcus aureus was very easily treated after the discovery of penicillin, and in 1950s the infection could be very well controlled with the help of the antibiotic penicillin. But then slowly this Staphylococcus aureus started showing a resistance towards this penicillin and would not respond to this antibiotic. So another semi-synthetic antibiotic, methicillin, was developed, and that was quite effective on this Staphylococcus aureus. But in 1960s, to be exact, in 1961, an epidemic of staphylococcal infection which were resistant to methicillin also developed, and these were named as methicillin resistant Staphylococcus aureus, and from here it got its name MRSA. When it developed resistance to this methicillin antibiotic, another glycopeptide antibiotic vancomycin was developed against it, and it was a potential antibiotic, and it was working on this Staphylococcus aureus, that too methicillin resistant. But then slowly this methicillin resistant Staphylococcus aureus MRSA started developing resistance against vancomycin also, and in 1997 intermediate resistance was developed against this vancomycin, which is a glycopeptides, and in 2002 a complete strain of vancomycin resistant staphylococci also developed. Now, what exactly is this antibiotic resistance? What is the mechanism behind this? I will show you an example of mechanism of antibiotic resistance. This is a diagram to show you a microbe which has got a chromosome and a plasmid. This is a bacteria with a cell wall, then cell membrane, cytoplasm. Now, when it develops a resistance against antibiotics, that means it produces an enzyme which inactivates the drug or the antibiotic here, or there is modification in the receptor, that is known as the drug target. So, it can either modify the drug target by altering its shape and its structure, or it can modify the cell wall protein, or they become capable of effluxing or the antibiotics which gets into its cytoplasm by activating drug efflux pump. So, the antibiotics which gets in is thrown out, effluxed out through this pump, and this is how it develops a resistance towards the antibiotics which is used against it. Now, as far as Staphylococcus aureus is concerned, the penicillin resistant, how it developed. So, the development of resistance is because of the production of beta lactamase enzyme. This enzyme is also known as penicillinase, or it may alter the penicillin binding protein site PBP2A, which is known as PBP2A, or it may develop tolerance to penicillin. Now, this production of beta lactamase, 4 types have been seen. 4 types of beta lactamase, these are the enzyme, and they have been designated as A, B, C, D, penicillinase. And the production of this beta lactamase enzymes is controlled by the plasmid, which is the extra chromosomal genetic material possessed by this organism. Alteration in the penicillin binding proteins PBP2A is chromosomal in nature, and there develops genes MECA in the SCC. SCC means staphylococcal chromosomal cassette. So, this new gene is developed, and which make it drug resistant, or they may have tolerance for penicillin, which will come and go off and will not affect, it will not kill the microorganism, but just inhibits its further growth. Now, let us see exactly what this beta lactamase does to penicillin. Penicillin is a beta lactam antibiotic because it has got a beta lactam ring as such, and this gets attached to the receptor of the organism. But then beta lactamase breaks a bond in this beta lactam ring here, it breaks the bond in the beta lactam ring of penicillin to disable the molecule, and the bacteria with this enzyme can resist the effect of penicillin, and not only penicillin but also of the other beta lactam antibiotics like cephalosporin. So, breaking the ring makes it inactivated. So, it becomes an inactivated penicillin which will not get attached to the bacterium and will not affect its will not do its effect on the bacteria. Now, let us go in the history of this MRSA. Initially, it appeared in hospitals in the 1960s, and it appeared in the hospital, and that is why it was also known as hospital acquired MRSA, or another name is healthcare associated MRSA. The short form is CA MRSA. They are highly resistant to commonly used antibiotics. It is not only the methicillin, but the commonly used antibiotics for any infection. These organism MRSA are highly resistant towards them also. And what is the risk factor which give rise to MRSA? It is the hospitalization of a patient, or it can nursing home residents if they are staying in a nursing home for a long time or working there. Then chronic dialysis, patient who needs chronic dialysis, going to the dialysis center very frequently. Irrational use of antibiotics also can make them resistant towards this antibiotics because of the different mechanism they develop against those antibiotics. Then use of invasive devices or like catheter etc., or some invasive procedure can introduce this MRSA in the person. Now, association with it is associated with increased morbidity and mortality. Once a patient get affected by this, the mortality and morbidity rate increases. Also associated with increased healthcare cost related to prolonged hospital stay, because if he gets infected once he comes in the hospital, and if he get infected by the hospital acquired MRSA, then the hospital stay prolongs, and to combat with that, intravenous antibiotics has to be given, and the treatment increases. So, the treatment cost increases. As long as the patient is there in the hospital, he cannot work, so his productivity is lost. He cannot attend his duties, and so that leads to lot of loss of productivity. Now, this MRSA from the patient are capable of colonizing in the nasal mucosa of the healthcare workers like the nurses, technicians, interns, doctors, housemen etc., and will localize there and will colonize there, and they can be a source of hospital outbreak sometime in the future. In 1990s, infection with MRSA begin to emerge in person without risk factor of CA MRSA, means hospital acquired or healthcare associated MRSA. Nothing was connected with the person who was harboring the MRSA, no risk factor of the hospital etc. And this new type of MRSA was identified as, they were seen in the community, and so they were identified as community associated MRSA. Short form is CA MRSA. Now, definition of this is of CA MRSA is person with no prior history of healthcare exposure like hospitalization, surgery, permanent device or hemodialysis, and still he is having the MRSA. So, those were called as community associated MRSA. What are the characteristic feature of this community acquired MRSA? Genetically, they differ from the hospital acquired or healthcare associated MRSA because they contain MAC4 resistant chromosome, and they are less resistant as compared to the HA MRSA, and they are more susceptible to the different antibiotics apart from methicillin or related one. Then they also carry a gene which is known as PVL, penton valentine leukocidin, which allows production of necrotizing cytotoxins, and which are responsible for increased invasiveness of the organism. Now, let us compare the hospital or healthcare associated MRSA with the community associated MRSA. Healthcare associated MRSA in that healthcare contact is a must, is always there, hospitalization etc., etc., which is not there in community acquired one. The mean age of the person who is infected with the hospital is older as compared to the community, which the patients are younger. Soft and skin and soft tissue infection is 35% in hospital acquired, whereas is 75% in community acquired. Antibiotic resistance to many other antibiotics apart from methicillin and related antibiotics is seen in hospital acquired, whereas it is not so with the community acquired. Resistance genes in hospital acquired is SCC MAC type 1, 2 and 3, whereas community acquired SCC MAC type 4 and 5. Then the strain types are USA 100 and 200 with hospital acquired, whereas USA 300 and 400 with community acquired. And PVL toxin genes is just 5% very rare in hospital acquired, whereas it is 100% in community acquired MRSA. Now, how do we control this MRSA, which is in the hospital as well as in the community? You have to recognize it, you have to do some intervention, treat it with, and you have to manage it. So, how do you recognize it? Methicillin susceptibility testing has to be done, methicillin, or you can also use oxacillin. Microbiology laboratories have an important role in detection of MRSA. There are two major methods for detection of MRSA in the laboratory: phenotypic methods and genotypic method. In the phenotypic methods for detection of MRSA, disc diffusion method, where we use oxacillin or cephalosporin for the testing, is very popular, very common. Apart from this, we also use dilution method for MIC, minimum inhibitory concentration, or E-test method, agar screening method, latex agglutination method, MRSA chromoagar, then automated methods. Disc diffusion method, which is the very common and popular method to be used, here we inoculate Muller-Hilton media with the strain in which we want to detect whether it is resistant or sensitive. So, that is inoculated, and on that we use either oxacillin disc 1 microgram strength or cefoxitin disc with 30 microgram plate, and it is placed on the inoculated Muller-Hilton agar media, and it is incubated for 12 to 24 hours. After incubation, we have to see for the zone of inhibition. Can you see here? There is a big zone of inhibition, means you do not see, this is the whitish opaque thing that we see, that is the bacterial growth, bacterial colony, but then there is no growth here, that is why you see a clear zone, a big clear zone is seen, no clear zone is seen in this disc, around this disc. So, half of has been inoculated with resistant strain and the half is inoculated with sensitive strain, and here the resistant one, you can see the organism is growing very close to the disc. It is not inhibited by this antibiotic oxacillin, or we can also use cefoxitin, whereas here you can see a big zone of inhibition. So, this is a disc diffusion method for the identification of MRSA. Now, why oxacillin and cefoxitin antibiotic is tested instead of methicillin, though we are calling it as methicillin resistant Staphylococcus aureus? Because cefoxitin is an even better indicator of MEC-A gene and disc diffusion test. Using cefoxitin gives clearer endpoint and are easy to read than test with oxacillin. That is why cefoxitin is preferred. Now, genotypic method. in phenotypic detection of MRSA, there is a difficulty by using standard phenotypic method due to heterogeneous expression of this methicillin resistant in many of the strains of Staphylococcus aureus. All may not help can be detected by this phenotypic method, the one we just now saw, this diffusion method. So, for this reason, detection of MEC-A or PBP2A by molecular method is very important, and PCR for the detection of MEC-A is gold standard method for detection of MRSA. Intervention for MRSA patient: wearing gloves can help reduce transmission. Then placing patients in isolation is strongly recommended. Cohorting the patient by moving MRSA patient to a separate area may be helpful. Patients with serious infection should be admitted to infirmary or appropriate inpatient facilities. And then hospital personnel should wear a clean non-sterile gown when entering the room if they anticipate that their clothing will have substantial contact with the patient. Masks should be worn for aerosol producing procedures. Adequate hand hygiene is the simplest, most effective infection control measure for preventing and controlling MRSA infection. Now, this is what we do in the hospital. Now, what about environmental control? Environmental control in this inmate housing area and bathroom facilities should be regularly cleaned with an EPA registered detergent infectant according to the manufacturer's instructions. Then recreational equipment such as weight benches should routinely, which everybody uses, should be routinely wiped clean after use with a clean dry towel. Then inmates should use barrier to bare skin such as a towel or clean shirt while using exercise equipment. Countertops and other traceable surfaces should be cleansed routinely after any contamination with blood or body fluid with an appropriate disinfectant. Laundry should be washed regularly with a detergent using a hot water cycle and then thoroughly dried. It should be thoroughly dried. Good hygiene post like wash your hands sign should be put everywhere wherever it is necessary. Gloves reduces hand contamination by 70 to 80%. You should catch the MRSA as early as possible and it should be isolated and treated. The antibiotic use should be reduced. Patients need to be educated that antibiotics do not work on the common cold or other viral infections. Provide appropriate treatment for appropriate disease. Standard universal precautions reduces the risk of transmission of blood-borne pathogens. Then it reduces the transmission of pathogens from moist body surfaces. Apply this to all patients receiving health care regardless of their diagnosis or presumed infectious status. Education is a key ingredient in the strategy of control of MRSA. Disease management involves a team efforts on the part of the correctional staff, medical staff and the patient. Thank you. किती मिनिटं लागली?